Dr. Gopal Pillai. Okay.
So we all know that proliferative diabetic retinopathy, laser is the mainstay, like Lalit sir right now told. So laser will be absorbed by melanin, and then it decreases the oxygen consumption to the outer retina. And then what happens is that through these scars, oxygen would come in, and the need for oxygen also reduces, and that reduces the VEGF production and reduces the neovascularization. Why would anybody use anti-VEGF? So PRP is the gold standard, but sometimes there can be macular edema worsening, or and then decrease of vision, peripheral vision, night vision. So all those problems also come with panretinal photocoagulation. And despite PRP, a lot of patients lose vision, and so there is an unmet need in some patients. So how does anti-VEGF act? It inhibits the VEGF level temporarily, so which means that the patient may require multiple. So laser reduces the stimulation of the retina to produce VEGF. So on the one hand we can reduce the VEGF, and the other hand we can reduce the stimulus to form the VEGF. So both are complementary. Now this is a patient who has cataract, moderate looking NPDR. So what happens is he underwent an uncomplicated cataract surgery and came after 6 months, and you can see that he had a bleed now. So maybe there was a small, neovascularization, or in 6 months he formed a neovascularization after cataract. So whatever it is, a laser was not possible at that point of time because of the cataract, and that is why, so such cases in which an anti-VEGF along with the cataract surgery or just before the cataract surgery can prevent these complications. This is again a worsening of diabetic macular edema after cataract surgery. After 3 months there was a worsening, and sometimes there can be proliferative diabetic retinopathy along with diabetic macular edema, and some large fronds which are flat but not so much elevated, in which a laser may precipitate bleeding. So we have 3 studies: Protocol S, Proteus study, and Clarity study. These are 3 studies on proliferative diabetic retinopathy where the effect of injection was studied. In Protocol S, it was like, initially it was planned for 2 years to anti-VEGF versus panretinal photocoagulation, efficacy and safety, and adults with type 1 or type 2 with no prior PRP, and vision score 24 or 20 by 320, that was basically taken. And prior PRP, TRDs or traction, neovascularization of the angle, dense cataract, all these were excluded also. So out of nearly 400 patients, about 200 were randomized, and 2-year visit was about 168, and 5-year visit was about 117 and 123. So about 60% of patients completed 5-year results. So here the treatment schedule was 3 injections of ranibizumab was given monthly, and then at 4 monthly effect. If it is resolved completely, then you defer the injection. Improved or stable, you will re-inject. Whereas PRP, at 16 weeks, the clinician could decide whether to add PRP, or if there is a vitreous hemorrhage or something like that, we wait for 2 months and then do a vitrectomy. So this was the criteria, and there was a rescue criteria also, failure and futility. So if there is a failure, then you would go for a panretinal photocoagulation. Associated DME, if it is more than 250 microns, was treated, and a treatment given for 12 weeks and then continued. So follow-up schedule was every 4 weeks for the first year, and depending on the clinician's discretion later. So after 5 years, you can see that ranibizumab, there was 117 and PRP 123 eyes, and this is the change in visual acuity is almost equal. By 5 years, you can see that both the graphs, initially there was an improvement for the anti-VEGF arm, but by 5 years they became almost equal. That is about 3-letter improvement. Worsening of 10 letters. Was higher, almost 1.5 times higher in the PRP arm, and 15 letters was about 8% and 10%. By 5 years, it became 6% and 9%. Still about 1.5 times higher of worsening of 10 letters. All right. Visual field, yes, there was a significant change. The laser arm had worse visual field than the ranibizumab arm. But at 5 years, there was some change in the ranibizumab arm as well. Vision impairing DME was more in the PRP group, almost double in the PRP group alone as compared to the ranibizumab group. So how many injections were required in the first year? Because there were 3 loading injections, 7 injections, and then you required approximately 3 injections every year. So there were 26 eyes who had to undergo rescue therapy with PRP, and PRP, about 71 eyes or 58% at least, one ranibizumab injection for diabetic macular. About 60% of the patients had ranibizumab injections. Now, if you look at total who received vitrectomy, again, double the number of patients who underwent PRP alone underwent vitrectomy as compared to the ranibizumab group. About double the patients had vitreous hemorrhage, and double the patients had traction retinal detachment in the PRP alone group. Adverse events, there was not so different actually. Ranibizumab is as effective as PRP, and 5-year results, the vision was good and no increase in serious complications and less visual field as compared to PRP. So more than half of the eyes in the PRP group received ranibizumab for diabetic macular edema, and ranibizumab treated eyes were less likely to require vitrectomy, and cost and risk of worsening disease if patient was treated with ranibizumab fails to return for appropriate follow-up was not considered. All right. So is visual acuity the only concern? We did not have fluorescence. Visual field loss in the ranibizumab group also at 5 years showed some decrease, and with 40% dropouts, there was some problems with the study. Then we come to the next study, the Proteus study, the ranibizumab plus panretinal photocoagulation versus PRP alone for high-risk PDR. We looked at regression of neovascularization. Okay, so baseline visual acuity changes and neovascularization and time to complete neovascular regression. There was 3 loading doses followed by 3 doses of PRP, and the other one was standard PRP. So, ranibizumab with PRP versus PRP alone, and looking at neovascularization, regression, etc. So 92% showed regression with the combination treatment. With PRP, only 70% of patients. And you can see that complete regression was seen, in 43% as against 25%. Time 3.6 months to 7 months. All right. So this is the best corrected visual acuity, which also showed a little better with ranibizumab with PRP, as well as central subfield thickness, which was better with the ranibizumab with PRP. So it showed the superiority of the combined treatment, especially in high-risk proliferative diabetic retinopathy. But this did not have the loading, so much injections like in Protocol S, which had a fixed dosing. So it had a short study period, and that is the limitation of this particular study. Then there is another study, aflibercept versus panretinal photocoagulation, just like the Protocol S. It's called Clarity, in which the BCVA changed from baseline to 52 weeks was what was taken. The best corrected visual acuity change from baseline to 12 weeks was the secondary outcome. So 116 patients in the aflibercept group, 116 patients in the PRP group, 3 loading doses, plus follow-up every 4 weekly. And then the other side underwent PRP alone. So total regression. The PRP group, the number of supplemental PRP laser required is 1.17, and aflibercept group by 52 weeks, patient received 4.4 injections, and that was it. This also showed that there was superiority of BCVA as against PRP alone, but it's a 1-year study. Now, patients with macular threatening TRDs, or whether there is traction, injections can worsen the traction. So you cannot extrapolate this to all proliferative diabetic retinopathies. So selection between PRP and anti-VEGF, you have to consider, the ability to be compliant, because patients who lose to follow up with intravitreal injections tend to behave a little worse. That is what is here. So eyes who are lost to follow-up that required panretinal photocoagulation, which are stable over years, they will continue to remain stable. Whereas the ones in which there is an anti-VEGF alone, they may worsen if they lose to follow-up. Now, so fresh vitreous hemorrhage 2 weeks, unlasered patient, you can wait for the hemorrhage to absorb, or probably give an injection which can give us some time. So over 3 months, 4 months, you can complete the PRP. Multiple neovascularization in one quadrant, you could, if there is no traction, give one injection followed by laser. So I did one study, a retrospective analysis of 568 patients. So this is before protocol. So I had 2 eyes of the patient who had PDR. The worst eye received injection with PRP. The better eye received PRP alone. And this was the total results. About 50% of patients had improvement in vision, 1 line, 2 line, 3 line, and 4 line. And about 30% people were stable. Bevacizumab with PRP versus PRP alone, you can see that a high percentage of patients of combination treatment had improvement of visual acuity, and a high percentage of patients with PRP alone had worsening of visual acuity. So currently in my practice, if there is no traction, if there is florid proliferative diabetic retinopathy, I would try to give one injection, complete laser. That is a recommendation what I think it is good. PRP is still the first line. There is nothing to beat PRP. Posterior pole disease, you could put one neovascularization. You cannot laser the posterior pole, obviously. So pre-vitrectomy, and when PRP may hinder occupation. So in Indian scenario, one anti-VEGF followed by PRP will be a little better, as shown by study also. Thank you.
Thank you, Gopal. Very lucid talk. I just would like to start with Dr. MPS. Many years ago, I think, just when Protocol S had come, I remember him telling that he had given a doctor-patient only anti-VEGF as treatment for PDR and had not done PRP. So is that patient still okay? Is he still on anti-VEGF only?
He was actually severe NPDR, not PDR, okay. But he is still okay. He is not had PRP as yet, so he is still on follow-up without PRP. Yes.
So any PDR patients you have only done Protocol?
No, none subsequently, because of the costs involved and the regular follow-up. Regular follow-up is something which is very important if you were to do the only anti-VEGF. That's a limiting factor. Other one was the visual fields. So that Dr. Gopal did show the visual fields. So despite the fact that the anti-VEGF does not destroy the photoreceptors, there was a decline in the visual fields sensitivity. So though not as much as the PRP. So that's something which is unexplained as yet, why the visual field sensitivity decreases just with anti-VEGF agents also.
Yes. So what is your take, sir?
I would not, presenting these 3 studies does not change my mind that I will shift towards anti-VEGF agents. The PDR laser because more than 3 decades back, what we have done, patients towards young IDDM, still maintaining 6/6 adequate laser, no need of injections. So many patients are there, not one. So, but there may be some set indications that despite PDR, if patient has recurrent ooze, despite good laser, we should not say despite laser, despite good laser, because good laser is not, all PRPs are not good laser. We see every day so many patients. Patient will come, say, Doctor, I had 4 sittings of laser, 5 sittings, but still that may not be a good laser. So if despite very good laser, patient has ooze, then I may consider adding anti-VEGF. Or if the frond is large, very large frond, which is slightly closer on the posterior pole, then I may add one injection. I may start with one injection, but laser still remains the mainstay. So till the time all PDR I have lasered adequately in a very good linear fashion till maybe beyond Vortex-N also. So anti-VEGF for me has an adjunct role, not a primary role.
So I'd like to just add one small point to it. I'm very fond of ultra wide field, and I think that is going to change the way we are managing these conditions by not a replacement, by modifying and making our PRP just the amount that is required. So in future, recruitment of more PDR, that is treating PDR by seeing more of the peripheral NV, is going to be an important point. Second is identifying the areas of ischemia and probably intensifying your laser at that point would reduce the field loss, reduce the amount of complications that are full PRP, and it can be done in a sequential way. If you take care of the CNP areas to a great extent first, that could itself produce the amount of regression you are looking for. And two, there is also I think it's a paper about the increase in the peripheral CNP areas because of use of anti-VEGF, and that could explain the field loss because of anti-VEGF itself. And one last point is that when you give anti-VEGF in NVE, we should also be very concerned about the crunch phenomena. The crunch phenomena is when you have neovascularization. I personally think when you have an NV at the arcades and it crosses the arcades into the posterior pole, like it straddles the arcades, those are the highest chance of getting the crunch. The whole arcades crunch and cause a TRD. So when you have these NV only on one side of the arcades, they don't tend to crumple up like that. But when you have multiple attachment points and you give an NV and you don't have control after the tractional component increasing after that, and that is something to be very aware of while giving anti-VEGF.
I just wanted to add one point that of late I have been seeing patients being referred or coming for a second opinion where they have received intravitreal anti-VEGF for VH. It's not even a known PDR patient so many times. It could be just PVD-induced VH, it could be traumatic, but that is not, it's not a panacea. You know, anti-VEGF doesn't take care of the VH. I think that point, because anti-VEGF has become accessible and affordable and easy to inject, it seems like it's a one-stop solution. That message should go strongly that there is a reasoning why anti-VEGF is being given. I don't know if anyone else on the panel has the same issues, but we are seeing a lot of, unrequired injections also being given for VH. So I just was asking, sir, is there a role of anti-VEGF injections, especially when you have an ooze post-vitrectomy?
In unlasered patient, no, never, because a big no. But in lasered patient, yes, you can. But it's not affordability, ease of injection, it's, I think, faster money.
Just taking the clue from Dr. Verma sir's talk. I'm just sharing my experience with a patient. One middle-aged lady, type 2 diabetic. She was presenting with proliferative diabetic retinopathy. I kept her on laser. She was very closely monitored, and I did a good laser in both the eyes. But she kept on having, small oozes, and then she developed one eye macroedema, which I treated with injection, anti-VEGF, and vision improved to 612, but often I find in these patients, they develop sort of a fibrous proliferation over the posterior pole, and that also accounts for the decrease of vision. So, and these cases differ in their course of progression. Some of them, they involute quite well with the response to the laser, but some keep on progressing. So, as you have said, adjunct anti-VEGF works, but this often is difficult to control maintain the vision because of the proliferative changes, the fibrovascular changes in the posterior.
No, adjunct VEGF does not mean that, they may require 1 or 2 injections. They are not maintained on injections. See, by and large, we have to pay attention because diabetic patients, remember, it's a metabolic disease. So you have to encourage all the controls of all the factors. Ultimately, if the laser is good, but I agree with Unni's comment that all of us should have access or should do, if not ultraviolet, if single frame, even with 50 degree, you can have collage prepared. But if everything is very well lasered, then this problem may be less. But if you depend only on anti-VEGFs, then this crunch phenomena and TRDs, posterior pole fibrosis, that may still occur. The fact that in case your patient has precipitation of fibrosis does mean that there is some activity going around. Some going around means there is VEGF being produced somewhere, and so that you have to take control, because laser also is anti-VEGF only. Laser destroys the anoxic area, so that hypoxic area, so that there is no production of VEGF from that place.
Sir, so the if you compare injections alone versus laser alone, it's a non-starter, because obviously laser is important. The question here is about why not get the benefit of one injection, which will quell the neovascularization quite well, and then do laser, which will reduce the number of vitrectomies that we are doing.
Yeah. But the problem, one injection is okay, repeat, because the problem, you rightly said, cost analysis has not been done. Because you can't maintain these patients on VEGF. I agree with one injection is okay, but message should not go that anti-VEGF is unlike DME.
Great.